Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners, and welcome back to another podcast episode. Today, we're going beyond opioids and diving into the multimodal world of pain management with none other than Tom Baribeault, DNP, CRNA, and founder of the Society for Opioid-Free Anesthesia, or SOFA, found at goopioidfree.com. SOFA is a nonprofit organization dedicated to researching, promoting, and educating both providers and the public on safe, effective, opioid-free strategies for perioperative care. In this episode, we'll explore why opioid-sparing doesn't mean pain ignoring and how to structure a multimodal pain plan from pre-op to PACU. Let's get into it. Hello, my favorite learners. Good morning. I am here with Dr. Tom Baribeault, DNP, CRNA. We are going to talk today about opioids and alternatives to administering opioids in the operating room and why anesthesia's kind of evolved into this practice. So thank you for being with us. Can you just tell us a little bit about yourself and your background and how you ended up in this specialty arena?
Yeah, my name's Tom Baribeault, probably most known for founding the Society of Opioid-Free Anesthesia, but I've also done a lot of work on intrathecal alternatives like Precedex, Decadron, buprenorphine, medications like that. I got really interested in multimodal analgesia while I was still in school. A project I did, a paper I had to do in presentation, and it just kind of went from there. People asked me to speak, giving that same presentation I had to do in school. And, in school, I had a little bit of freedom to experiment with it. My first job out of school was just starting an ERAS program. So I spent a lot of time using ketamine, lidocaine infusions. We didn't really have Precedex at that point. We were using clonidine. And it was shortly after that it went generic and we could really start using Precedex more. And it just sort of developed from there, doing a lot of regional anesthesia and teaching regional anesthesia shortly after I got out of school and incorporating that into my clinical practice.
Nice. So I actually had our fourth child was via C-section and I had an opioid-free anesthetic. So they actually gave me intrathecal Precedex. So from the patient perspective, and they gave me IV Precedex for shivers afterwards as well. But the whole time I went home, no PO meds, opioids at all. So I am someone from a patient standpoint that appreciates you because it does really benefit patients. No nausea, vomiting, none of the sequelae that come with that. So going into our first question, we hear a lot about those side effects, right? The ileus, nausea, vomiting, respiratory depression. So what are your thoughts about why in anesthesia we've kind of moved towards this non-opioid anesthetic technique?
Yeah, this is one of those areas where it's sort of great to understand the entire history of it. I think a lot of times we sometimes go into anesthesia and we know the way we've been taught, and that's sort of not the whole picture. When fentanyl was invented in 1960, it was very rapidly incorporated into anesthesia, and that's where we heard about, the high opioid techniques. And because prior to that, we weren't using a lot of opioids in anesthesia, and the volatile agents we had at the time were a lot less hemodynamically stable. And so by being able to reduce the amount of volatile agent we were using and replace it with a dose of fentanyl probably saved a lot of lives. And think about at that time, we were just starting to really do a lot of open heart surgeries and have those really hemodynamically complicated and unstable patients. And so that's why we started using fentanyl in anesthesia, and we probably saved a lot of lives, like I said, doing that. And over time, we've been slowly becoming more aggressive with our multimodal analgesia, right? We started with even that term, multimodal analgesia, which basically meant giving Tylenol and Toradol. And then along came the ERAS programs, and we started doing a lot of lidocaine infusions, a lot of ketamine, doing a lot more regional anesthesia. And when we made that move, we needed a lot less opioids. And then 10, 15 years later, the opioid-free movement started. And basically what they discovered was that we can essentially just do, an intensely multimodal technique, and we no longer need the opioids. The only thing that they're providing at that point intraoperatively is side effects. And the idea of opioid-free anesthesia freaks a lot of people out. They feel like they're taking something away from the patient. They've spent 10, 20, 30 years doing an anesthetic with them, and when you tell them you can't have this foundational drug anymore, it's like you're telling them they've been doing a bad job giving anesthesia for 30 years, or that you're taking away their safety blanket. So a lot of people have this sort of visceral response to the term opioid-free anesthesia, but the reality it is that it's just multimodal analgesia, but we've gotten good enough at it, and we've learned enough about the medications and the side effects of opioids that we don't need them anymore. The only thing they're really contributing to our anesthetic at this point is side effects, respiratory depression and nausea being the two biggest ones.
Yeah, I think you're totally right. And I know personally, at our facility, I've tried to be a part of the initiative to move towards non-opioid anesthetics. And so I've had to hand over cases, and I'm like, okay, listen, I've been doing this. Please continue with it. They're going to look to Kipnick, and you're going to want to give narcotic. Don't do it. Unless they wake up and if they wake up and they're uncomfortable and you're here and you want to give narcotic, fine, go for it. But if they will wake up and they won't be in pain. But that's tachypnea. I think, like you said, it's that we're so used to treating tachypnea immediately with narcotic that it makes people really uncomfortable to not do in practice.
No, absolutely. Anytime you do a different anesthetic technique, it kind of looks and feels a little bit different. And, I remember the first couple times I did it, I had to hold my hand back because it kept darting over trying to grab the fentanyl. Because I had no idea what was going to happen. I didn't have anyone to tell me this is how you do an opioid-free anesthetic. It was just I was only giving a half cc of fentanyl to my cases, and I thought logically, why am I still doing this?
Right.
2 hours later, this is providing nothing for my patient. But I'd never done one, other than shoulder surgeries with a block or whatever. I'd never done an opioid-free anesthetic with just IV multimodal drugs. And so I had, drawn up the fentanyl, labeled it, set it on my anesthesia machine, thinking that if worst case scenario, the patient gets really tachycardic or whatever, I can reach over and grab it and give it pretty quickly. But yeah, no, you get that respiratory rate of 20 to 30 at the end of the case when they're breathing spontaneously. And in your head that that's just the effect of the volatile agents. We all learn that in school. They increase respiratory rate and decrease respiratory depth. But until you give an opioid-free anesthetic, you've never actually seen that because you've been blunting that response with fentanyl the whole time.
Even with my C-section, I remember the anesthesia team, I was like, I don't want Duramorph. We've seen the patients, they're miserable, they're puking for multiple reasons, right? But we can't rule out that it's not from the narcotic intrathecal, and they're itching, their nose, their face is itching, and I was like, I just don't want it. And they were begging me, just let us give you a little bit, because they didn't want to take the risk of me being in pain. And I totally understood that, but I was like, just do Precedex, and then they did a tap block with Exparel. So I felt like I was safe and comfortable, and at the end of the day, I didn't need any of it. So I hope the team, and I know they did because I knew them, they went back and were able to be like, wow, that patient did fine and wasn't miserable, because we worry about patients in that way, So was there any turning point for you, whether it's clinically or I guess clinically, in patients, where you saw it and you're like, okay, this is actually something I want to do and the initiative I want to start?
Yeah, I had that moment where, I just sort of asked myself, why am I still giving fentanyl? I was in this group that was very heavy into ERAS, and so they were all getting Tylenol and Celebrex and gabapentin preoperatively. We were giving bolus of ketamine on induction. We were either doing a block or running a lidocaine infusion. And I had taken a step further and started adding a little bit of IV clonidine in there as well. And I was giving like a half ml of fentanyl, 25 mics on induction, and that was it. And I had to ask myself, like, why are you still doing this? And, so I just decided one day not to. And, that entire week, all my patients did so much better. It's that thing where you take them off the vent and reverse them, and they're immediately breathing. So it was like an easier, safer anesthetic because there wasn't any respiratory depression. They had much less nausea, much less pain post-operatively, and had to just sort of ask myself, like, why are the patients doing so much better? You take away an analgesic and they have less pain. That doesn't really make sense. And I knew about opioid-induced hyperalgesia, and I had learned about opioid tolerance, but until you really see that and how profound even these small doses of fentanyl can make it, you don't really understand how much it impacts our patients. So I started doing some research. I started talking to people online. This is when the big Facebook groups had just sort of come out. And so I was posting on there and talking about it. And the other thing that was happening at that time, this was 2016, 2017, is the opioid epidemic was really ramping up. And, I was working in Kentucky and right along the highway from Mexico to Canada. We had refrigerated trucks filled with overdoses, the bodies of people who had overdosed, just because the morgues couldn't hold them all. It was getting a lot of media attention. So there was a lot of people looking for how can we reduce our opioid use. We were starting to see a lot of patients come into the hospital who had been addicted and gone through recovery and were concerned about relapsing from opioids during surgery, and they were starting to ask, is there any way I can have this surgery without any opioids? And so it was really kind of like all those things came together at the same time, and the anesthesia providers were asking the questions, how can we meet these needs? The patients were asking the questions. And I quickly found myself overwhelmed with the amount of people who wanted information on this. And so really I started the Society for Opioid-Free Anesthesia to kind of gather in the experts in this field and help me kind of get the information out there to the people who wanted it and needed it.
I love that. Yeah, I didn't even think about all the people in recovery, and the opioid epidemic obviously has something to do with it. But when you think about patients, I've had patients definitely say to me, like, is there any way? And back in the year 2000, we would have been like, absolutely not. Like, there's no way we can do this without an opioid. And they would have, had to go through it with. But now we have other options thanks to people like you. So thank you for supporting people in sobriety. I think everybody listening knows somebody in sobriety. That's awesome to give back to the world in that way. So you've said before that multimodal analgesia isn't just checking off a list, which anesthesia in general is not recipe-based, right? But it's more of a strategy. So how would you want to tell our learners to build a plan for a non-opioid anesthetic?
So the way I like to approach it is to just look at the pain pathway and really learn all the neurotransmitters, all the receptors, and so you can build a list in your head or a plan of all these medications and what receptors they each occupy, or where in that pathway they work. Pain is such a complex process, and there's so many different ways to intervene. And so if you think of it from a mechanism-based approach and just try to hit as many of those mechanisms as possible, while at the same time taking into consideration the patient's history and which medications may not be appropriate for that patient, right? If they've got history of seizures, we may not want to run a lidocaine infusion, things of that nature, So, and the other thing I like to think about is we have such a high rate of chronic post-surgical pain. And so understanding the pathophysiology, how our nervous system gets sensitized to pain through the inflammation brought on by tissue destruction during surgery, and how that changes not only the peripheral nervous system but also the central nervous system, and start with the medications that help to block or prevent that process. And basically what we come down to is, ketamine and Precedex are probably the strongest options in our armament that we can easily use. And then either a block or a lidocaine infusion. Magnesium is very helpful as well, but kind of doubles up on the same mechanism that ketamine uses, and so not necessary. It's helpful, certainly. So that's when you look at the literature about opioid-free anesthesia. Most of the time you're looking at using ketamine, Precedex, a lidocaine infusion, and or a peripheral nerve block, with or without magnesium in it. And if you had to kind of define opioid-free anesthesia as by the drugs we use, that's how you would do it.
I love that. Yeah, with my courses, I'm really trying to, and I feel like the new generation of learners is really into like, why do I need to know this? Like, why, when I think about learning the pain physiology and the pain pathways, my eye starts to twitch. I mean, it's one of those topics that I'm like, it's really hard to conceptualize, really, when it's just a different way of thinking for me personally. But it's nice to hear from you that like, these are the reasons why we learn these things academically, because clinically it really matters and we can really improve surgical outcomes or anesthesia outcomes for our patients.
Right. And, you think about the fact that pain is something that every single one of our patients is going to go through and experience, right? We spend how many months on just cardiac physiology, and what percentage of our patients are healthy enough that there's really nothing you could do to cause them significant cardiac problems. Certainly we have the sick patients, but pain is something that every single one of our patients is going to experience, and we're supposed to be the experts on that. But most of our programs, if we get an hour or two of lecture on pain pathways and how all those medications really interact with the pain pathways, we're doing pretty good. I think we're not spending enough time teaching about that.
Yeah, I agree. Totally. I've never thought about it that way, that you cannot have surgery without pain. That's what we always tell patients, right? And just to set the expectation, like we're not completely not going to have any pain, but something that's tolerable and manageable for post-operative period. But every single patient is going to have it. I love that. I agree with you. It needs to be emphasized more academically. So you've kind of already done this, but I want you to kind of walk through, we're going to go through specific surgeries, and what you would do for these patients, but can you just kind of walk through a case and a multimodal plan where you don't want to give opioids at all?
Sure. So this is kind of just to sort of start this conversation off. There's a lot of things that we do, or that were sort of introduced by the ERAS programs, the oral medications, right? The Tylenol, the NSAIDs, maybe a gabapentin or a antidepressant, an SSRI. And all those things really help with post-operative pain control, but they really don't change what we do intraoperatively. And that's where opioid-free anesthesia is a little bit different, as it really focuses on that intraoperative experience and keeping heart rate, blood pressure under control, not giving so much that the patient has a hard time waking up or a prolonged PACU stay, right? This still has to be a functional anesthetic. We still have to have stable vital signs intraoperatively. The patient has to go to sleep and wake up when appropriate, and have reasonable expectations that their pain will be under control. Like you said, everyone's going to have pain. You can't have surgery without pain, but it should be controlled to a reasonable level when they wake up. So anything that you can do in those ERAS programs, Tylenol, Celebrex, gabapentin, you can still do that as part of the opioid-free anesthetic to help out with post-operative pain control. But really, as far as opioid-free anesthesia, what we're talking about is replacing the fentanyl with some combination of Precedex, ketamine, either a block or a lidocaine infusion, and magnesium. And people are like, well, you're replacing one drug with 4 drugs. You're making things really a lot more complicated. But the reality is, kind of the way I do it is that my Precedex replaces the Versed, my ketamine replaces the fentanyl, and I'm going to be giving the lidocaine anyway. So it's the same amount of drugs, it's just a little bit different doses. It's not any more complicated. So I like to start giving my Precedex in pre-op, and that's because Precedex has a long onset. It takes about 10 minutes to reach its peak effect, and you can't give it quickly, right? You get that sort of paradoxical hypertension if you bolus it too quickly. So, I dilute it. You can either use the dilute 4 mics per milliliter. If you have the concentrated vials, you can just dilute it down to 10 mics per milliliter and start titrating your dose in pre-op, and the goal being to get about a half mic per kilo, 25 to 50 mics on board as you're heading back to the operating room. Once you're in the operating room, you get the monitors on, pre-oxygenate. As I'm inducing, I give a bolus of lidocaine, and my bolus is a little bit bigger than what you typically, the 50 to 100 milligrams you routinely give to reduce the burn of propofol. I give a full 2 milligrams per kilo, so it looks more like 150 to 200 milligrams. And then I'll give a half milligram per kilo of ketamine in place of the propofol, rocuronium, anesthetic you want to use to actually put them to sleep and paralyze them. And obviously, if it's going to be a really short case, I'm going to reduce those doses down a little bit because they're all very long-lasting drugs. They don't have any reversal agents. So really short cases are probably the most challenging ones to find a balance of keeping their heart rate and blood pressure under control and still letting them wake up, when you've only got a half an hour anesthetic. And we find ourselves using a little bit of esmolol in those cases if you need to, using a smaller dose, maybe a 1/4 milligram of ketamine and a 1/4 mic of Precedex per kilo. And supplementing with some esmolol if as needed. Really, it's as simple as that. If you have a case that is longer than 2 or 3 hours, it really behooves you to run an infusion. We don't do a lot of that in anesthesia, and I don't know why. I think we have so many short cases that it's just not worth setting up the IV pump. But once you get to about the 2-hour mark, it really is just easier to start running an infusion of all 3 medications of ketamine, Precedex, and lidocaine. And, I don't like math and I don't like complicated things. It just makes it too easy to mess up. And so really my doses here, I start at 0.2 mics per kilo per hour of Precedex, 0.2 milligrams per kilo per hour of ketamine, and 2 milligrams per kilo per hour of lidocaine. And that seems like a lot of math right there, but there's a really simple way to make that work. And what that is you get 2% lidocaine and you add 2 milligrams per milliliter of ketamine and 2 mics per milliliter of Precedex to it. So if you've got like a 20 ml vial of 2% lidocaine, it's 60 mics of Precedex and 60 milligrams of ketamine. And then you run that at 0.1 mLs per kilo per hour. So 80 kilo patient runs at 8 mLs an hour.
Wow, very cool.
So really easy math on that. And you can go up or down by 50%. I wouldn't go up more than 50% because of the amount of lidocaine you're giving, but you can safely go up by at least 50%, but I rarely have to do that. That is pretty profound. And I've even started doing that on MAC cases, is running that infusion, and it's crazy how much less propofol you need to keep the patient comfortable when it just has such a profound analgesia to it that really you only need enough propofol to keep them amnestic. You're not like giving excess propofol because, to sort of counteract the fact that you can't give enough analgesic because of the respiratory depression. When you've got 3 different analgesics that work on different receptors that don't cause any respiratory depression, you can create this really profound analgesia, and they're so comfortable, even if the surgeon's not good with local, even if it's not a block case where you've totally anesthetized the area with a block. They're just so comfortable on that you don't need nearly as much propofol to keep them comfortable. And you see the same thing when you're doing a general anesthetic, right? You really only need a half to a third a mac of gas, or a half a mac to 2/3 a mac of gas, which also is partially due to the fact that they all have a little bit of a sedative effect, but it also kind of helps them wake up quicker. Because you haven't had to compensate for the fact that you can't really give enough analgesic or fentanyl because of its respiratory depressant effects.
And I love that you mentioned esmolol, because I think that I was reflecting as you said that, because I think that was my first introduction to non-opioid anesthetics. It was like a study that I read in like 2016 that was like, are we giving narcotic every time the patient's tachycardic when we could be giving a little esmolol to get them through that? And then at the end of the case, they're hard to wake up because we've given fentanyl every time they have an increased heart rate. So yeah, it's really interesting to hear that technique. I need to, when I re-listen to this, I'm going to be taking notes and writing all of this down because it's great. So you talked about it pretty specifically. How would you, I'm going to go into different surgeries basically. So how would you alter that for like a laparoscopic hernia repair, for example? Is there anything you would change to that multimodal anesthetic you just mentioned? Or pretty much that's how you would do it?
No, pretty much that's how I would do it. And I've done that anesthetic for everything from that hernia repair under MAC, with an LMA. I've done that up through major thoracic and vascular surgery, thoracotomies and big painful surgeries, pneumonectomies, things like that. So the one thing I'll say is very, very, the big difference to me is the duration of the surgery. If it's an hour to 2 hours long, I'm going to give that initial bolus, and then I'm going to have my ketamine and my Precedex and my lidocaine drawn up in syringes. I dilute it down to 10 mics of Precedex, 10 milligrams of ketamine, and just my normal 2% lidocaine. And so for a short surgery, if I've got a lap appy, a lap chole, the lap hernia repair, things are going to take an hour to 2 hours. I give those, that's pretty standard initial bolus for a healthy person. If they're really sick, I'm going to obviously back it down a little bit, or really old. But if they get tachycardic or on induction, laryngoscopy, incision, I'll give 10 mics of Precedex and 10 milligrams of ketamine at a time. Kind of like that's my cc of fentanyl. And then at the end of the case, I'll give an ml or 2 of that. If it's been an hour and a half since I've given anything, I'll give them a little bolus at the end of the case. Anything over 2 hours, it's just easier and less work to put it all in that syringe and just run an infusion of it. And talk about train tracks, right? You reach a steady state of those drugs and your anesthetic, there's no rebolusing, redosing, and you still have that sort of maximum plasma concentration of analgesia on board when they're waking up. And so that sort of magical wake up where they open their eyes and they're perfectly tolerating the endotracheal tube. They're breathing great. They say, yes, please, would you take this out of my mouth now? And off you go with them, their hands behind the back of their head.
That's the best feeling too. Yeah. I used to love a narcotic wake up. That's what we used to call them, right? When they were tolerating the tube so well, they open their eyes, that whole picture you just painted is what I used to love about narcotics. What I want learners to hear from this is that you can do it without narcotics. You don't need narcotics for that narcotic wake up, but it takes coming out of our comfort zone of the bubble of relying on narcotics to do that. So I really appreciate you sharing all of this. This is awesome. What about for a total knee arthroplasty, with a spinal? Would you do just the sedation the same with those medications, or?
If it's under spinal anesthesia and I've got a good spinal working, I give much less of those medications. Typically, what'll happen is we roll into the operating room. I'll give them 10 milligrams of ketamine and 10 mics of Precedex as sedation for the spinal. Do the spinal. I'll give them another, once we lay down, start the propofol drip, and I'll give maybe another 10 milligrams of ketamine just for good luck right when they make incision, because even as long as I've been doing this, the anxiety is still there. The question, is it going to work, is still there, but rarely need it. And what I like to do is keep my propofol at about 50 mics per kilo per minute. And then if they show signs of being awake, give little boluses of Precedex to keep them asleep. When you do it that way, there's a lot less respiratory depression. You're not having to put oral or nasal airways in. You're not jaw thrusting. You're not fighting any significant respiratory depression. And the Precedex for sedation is very potent. And really, I'm just sort of relying on the propofol for a little bit of amnesia so that they don't remember that saw. And not that it's hurting them, but it would be a little disturbing to me to like hear the chainsaw going and being like, oh, they're using that on me right now. So I'm just want the propofol there for a little short-acting amnesia. And the Precedex is really like my go-to for like making them sleepy and not talking to me.
Yeah, I have colleagues that I've used Precedex for like MAC cases, and they've joked and they're like, this is an essential oil. They've called it like the essential oil of anesthesia. And I'm like, it's at that point, if you think it's an essential oil, it's user error. That's always my response. User error at that point, if you think it's an essential oil. But I don't have this question prepared, but my question is, with all this ketamine that you're administering without the Versed, because that's kind of like the uncomfortableness that I have in giving ketamine without, because you say you don't use Versed, correct? Do you
Rarely.
find kind of trip out at all, or any side effects from the ketamine?
No, and here's the trick. Here's how it works: is that there's a band of plasma concentration of ketamine. If you imagine it on sort of an XY axis, right? You know, the first little band you'll notice is just analgesia. That second little band is the hallucinations and dysphoria, and then the third band is anesthetized, like their brain is completely turned off. And so you have to be, if you have an awake patient, you have to be here or here. You can't be in the middle. And where Versed would come in is when we had patients where we were giving big induction doses of ketamine too, right? And so we would anesthetize them with it, and then we would give them the Versed to kind of help them sleep through that coming down, metabolizing through the hallucination and dysphoria phase. Most of the time with the doses we're giving now, the analgesic doses, the 1/4 to 1/2 milligram per kilo doses, we are immediately putting them to sleep or giving propofol that does the same thing, right? It makes them sleep through that phase where they're in the hallucination phase. And by the time we get to emergence, they've metabolized and come out of that. Alternatively in OB, when I've got a labor epidural, dosed it up for a C-section, there's one little spot that hurts, or, the classic thing is they're great through skin incision, but when they get to the uterus, they're intensely uncomfortable. And you have to give a little bit of ketamine. If you have to give enough ketamine that you bump them into that zone where they're going to be hallucinating, one of two things: either give more ketamine and get them to an anesthetized state, or use baby doses of propofol or Precedex to complement the sedative ability, get them to sleep, so that the ketamine is metabolizing out, and as they're waking up from the sedation of Precedex.
I love that. Yeah, because I don't know how many times I've taken patients to recovery and I've given 20 of ketamine for the ERAS protocol on induction, and they're like, the packing nurses will say, oh, they're so confused because of that ketamine. I'm like, I don't think 20 milligrams of ketamine is where we're at right now.
And that goes back to that. They're used to the standard anesthetic, the gas fentanyl anesthetic. And so when they see something different, it like triggers them, and they blame that, right?
It's like just a barrier to practice, I guess. So in terms of, you mentioned it a little bit earlier, but chronic pain patients. So how do you approach chronic pain patients with this non-opioid technique?
So, I'm going to divide them into two sort of separate categories. The standard chronic pain patient who comes in, who's on, gabapentin and Cymbalta and those types of agents, but not an opioid. I'm going to treat them exactly the same. If I'm going to do anything, I might bump up my doses a little bit. Like I sort of keep saying, the biggest problem with opioid-free anesthesia is having a patient who's sedated for a long period in PACU. And so, it's hard to tell intraoperatively where that barrier is going to happen, or where that dose is that's going to do that. So I might bump my doses up a little bit, but that also is going to be someone that I might be a little bit more aggressive. I might start getting the magnesium. I'm going to make doubly sure that they've got big doses of Tylenol and Celebrex and all of those drugs ahead of time. Make sure that they've taken their daily dose of gabapentin and Cymbalta and all of those medications. So the big thing is they get treated exactly the same. I just sort of understand that I might need an extra medication or two. I might need a slightly bigger dose. And the nice thing for the patient is all of the medications we use for opioid-free anesthesia are used to treat chronic pain as well. They're used to sort of reset the nervous system. We've all heard about the ketamine infusion clinics and people doing that for chronic pain. And Precedex does a similar thing. And there's literature out there on using lidocaine infusions for chronic pain. The literature's out there for using all these drugs to treat chronic pain. So they not only are going to have good pain control post-operatively, but they may notice a decrease in their chronic pain for a period of time. The other group of patients are the ones that are chronically on opioids, right, as part of their chronic pain regimen. And for them, I'm going to do the same thing, but I'm going to add opioids to it. And I'm going to make sure that they've taken their daily dose, whatever they normally take, and I'm probably going to add a couple milligrams of Dilaudid or whatever on top of that. Because, like I referred to in the beginning of this, if you think of opioid-free anesthesia, not the goal being the elimination of opioids, but just its multimodal therapy to the point that we don't need opioids in most patients. This is a patient population that still needs their opioids, right? We don't want them going through withdrawal from their opioids at the same time that they're going through the pain and stress of surgery, and not only all the withdrawal symptoms, but also the rebound pain that comes along with it. And so they're going to get my standard opioid-free anesthetic plus opioids.
Which makes sense, and it's holistic, right? And with the surgeons preoperatively and the whole team postoperatively, everybody kind of has to be, even for a regular patient, everybody has to be on the same page, right? I have to educate the PACU nurses, like, I'm trying to do a non-opioid. If they need it, sure. But, I always get frustrated when they're like, oh, I'm going to go get fentanyl. I'm like, well, let's try, do they need it? And let's kind of work together for this. But when patients come in on chronic opioids, there's only so much we can do at that point, right? The team's already made that pain decision pre-op, and we can't totally change the course of their plan either. Just like the PACU, we don't want them to change our plan. So it's really holistic in that sense. So how do you recommend, going back to this team approach, how do you recommend changing this practice? Because that's been my barrier. I told you about my colleague that called it an essential oil, and the PACU nurses that have given me a hard time about ketamine. So how do you suggest to our learners to get the team to trust you and to implement these new strategies?
Yeah, so there's two approaches to doing this. And the first approach that you can do just as individual Joe anesthetist out there giving anesthesia is look for the opportunities, look for the patients that are going to really benefit from it. And if you think about sort of the three biggest benefits of opioid-free anesthesia being lack of respiratory depression, decreased postoperative nausea, vomiting, in decreased pain and or sort of treatment of chronic pain. And we can even add a fourth in there. We can even add the formerly addicted that are clean now, right? Look for those patients that are going to especially benefit from it. And when that patient comes to you who says, every anesthetic I've ever gone through, I've had post-operative nausea, vomiting for 24 hours afterwards. I have to be admitted after surgery every time. And I can't tell you how many patients I've had tell me that who have had 3, 4, 5 surgeries and had to be admitted just for management of that and done an opioid-free TIVA, and they get to go home same day, and that's not only good for the patient, that's good for the hospital, right? That's a huge cost savings. So look for those types of patients, the really sick pulmonary cripple getting a pneumonectomy or something, and they're thinking, we don't know if we're going to be able to extubate at the end of the case. Any of those situations, and say like, hey, let's do an opioid-free anesthetic and see if that gives us a better outcome. And so that's kind of the standard way to sort of get people to trust you a little bit when they start to see, like, you took this patient with chronic post-operative nausea, vomiting. You took this really sick pulmonary patient and got them extubated. You did a 12-hour spine on a patient with chronic pain for 20 years and multiple spine surgeries, right, and got them through that, without having to narcotize them to the point that they have to remain intubated or they had uncontrollable pain in PACU. And then people will start to see your outcomes and to trust you with it a little bit. So that's one way to do it. The other way is when you're in a position where you have a little bit of trust and ability to talk to people, a little bit of a leadership role, you look for the surgeries and the surgeons that are kind of struggling. The standard ones that we see where opioid-free anesthesia fits in really well is bariatric surgery, because you've got these patients who don't breathe very well, because of their obesity. They seemingly have very high rates of post-operative nausea, vomiting. And the last thing you want them to do is vomit and rupture their suture line in their stomach. And they seemingly don't handle pain very well. So that's one surgery and one patient population that there's a lot of benefit to doing opioid-free anesthesia for. Major breast surgery is another, because there's a lot of post-operative nausea, vomiting. Major spine surgery. We talked about thoracic surgery. Really sick pulmonary patients. Go to the surgeon. You go to, if there's an anesthesia provider who's sort of like the team lead for doing it. You sit down. You have a meeting. You say, hey, let's improve your outcomes. We're going to do this protocol. We're going to make a protocol. Everyone's going to do it the same way. We're going to look at our outcomes. If the outcomes aren't good, we're either going to modify our plan or we can go back to the way we were doing it. But I really think we can make a big difference for you, the surgeon, and for the patients, right? And then the anesthesia providers get comfortable with it because there's a protocol. Something weird happens. It's like, well, I did it according to the protocol. It's not like you did something weird and the patient had a weird reaction. So they're a little bit protected. They're comfortable because they have a written outline of how to do it. And the patient's happy because you're doing something to help their patients out and you're caring about their outcomes more than just showing up to work and doing an anesthetic. And, everyone behind the drape does it a little bit differently. So the surgeons are happy as well. And again, if you can cut down the amount of days the patients spend in the hospital is really happy. And you can make sure you gather that data as well to take to hospital administration, say, look what we did. We're saving you this many millions of dollars this year by doing this opioid-free protocol. And you'd be surprised how many hospitals out there aware of the opioid crisis, and want to celebrate the wins. How are we helping this problem? But they just, if you don't tell them what you're doing, they don't know.
Yeah, I think you've mentioned it in both scenarios that communication is key, and it takes a lot of energy to do that as anesthesia providers who are used to just doing the cases, going to sleep, waking up, and doing the thing. But it takes communication with the entire team, whether it's pre-op, PACU, surgeon. I think everybody wants to see patients do well, so that's a big bonus for everyone. It's those communication, that talking to get people on board to how can we improve these outcomes and help patients. And then another thing you mentioned too is finding, which is why it's kind of a hot debate on whether a DNP is worth it for a nurse anesthetist. And I'm one of those that thinks it really is. And this is one of those scenarios where you have to find key stakeholders. And that's the whole DNP process, is finding key stakeholders, getting them their buy-in, right? And just like you said, the hospital wants to save money. It's about money for a lot of businesses at the end of the day. Medicine, unfortunately, is also a business. And so giving those key stakeholders something in non-opioid anesthetics, like decreased admissions and stays, PACU stays, and admissions after surgeries, is super important. So I think it even highlights full circle, the DNP process and how we can actually implement these things in practice, which is great. Not everybody loves the DNP process, but
100%.
The students listening will be like, yeah, right, lady, but
whatever.
yeah, well, you can make a difference, and I'm so glad you're here, because this shows that CRNAs can take something as mundane as the DNP process, use it in practice, and really change patient outcomes, which at the end of the day, everyone can agree is what we're here to do. So the one thing I'm going to end this podcast with, I thank you so much for your time. We're almost at an hour, which is fabulous. I'm asking every guest to give one piece of advice or encouragement. It can do with non-opioid anesthetics. It doesn't have to. But for a learner in the throes of anesthesia school, what's one piece of advice or encouragement that you would give them? Kind of a deep question.
Oh yeah, that's my big thing right now has to do with all the CRNAs and SRNAs out there who get imposter syndrome. And feel like there is, and rightly so, because there's this mountain of knowledge. And even if you take all the amount of knowledge that all of humanity has put together on the human body, we still don't understand it, right? But it seems like there's a lot of anesthesia providers out there who are giving anesthesia but think there's some magical, mystical knowledge that they don't have that is sort of beyond them, that other people have, and it makes them feel less than and gives them this imposter situation. Let me just encourage you, anesthesia is as sort of, I don't want to call it a blue-collar profession, but it's really a hands-on thing, and there's nothing out there beyond your patient outcomes. If your patient goes to sleep when they were supposed to be asleep, remained anesthetized and motionless through the surgery, you woke them up without pain, without nausea, breathing well, you did the job. You did what it is to be an anesthesia provider. You made the right decisions. You are the definition of an anesthesia provider. You are it. And there's not this magical outcomes beyond that. So, just take that to heart, that and especially senior SRNAs, this is my favorite thing to do. When I go in and I've got a senior resident, their last couple months, and they go and they pre-op the patient, they do the anesthetic, they nail all their techniques. I'm basically a shadow. I'm worthless. I'm not talking to the patient. I'm not touching the patient. And I get to the end of the day, and I haven't said a word to any patients. I haven't touched any patients. I haven't done a thing. I haven't had to answer a question. And I get to the end of the day and I say, do you realize what you just did? And they all just give me this blank stare with a little bit of panic and fear in there. What do you mean? I said, you did it. You did the job. You are ready to go. You're an anesthesia provider. None of us, even as anesthesia providers, are going to nail every single intubation and A-line and central line and block and spinal and epidural. We're all going to have a moment where we either struggle and take a really long time to do it, don't do it well, have to call in for backup. I mean, none of us are perfect, and there's some people that are better than others, but if you can go to work, make safe decisions, get your patients through their anesthetic with a minimal complications, that's what it is to be an anesthesia provider. There's nothing more beyond that. So that's my encouragement to the CRNAs that listen, to the SRNAs that are still in that process of going from knowing nothing to drinking out of the fire hose and being told what to do step by step to learning to make those decisions. Really, what you need to do is learn to make safe decisions. If you can make safe decisions, even if your safe decision is get someone in here to help me with the intubation, ask the question about the physiology that I don't quite remember, and get someone else to kind of refresh my memory or look it up. That's what it is to be an anesthesia provider, is to make safe decisions.
I love that. And I found fulfillment myself in just that scenario you were describing with the seniors and seeing them upon graduation. I'll never forget it. I did an open AAA. I had 2 seniors with me because it's such a big case. And I basically just sat there during this open AAA, like watched them vigilantly and the patient and all that, but they did the whole anesthetic. And at the end of the day, they'll never forget it either, because it was really a fun learning day, and the patient did well, and it just gives you such a sense of fulfillment as a CRNA. I know not everybody is so into like educating students, and now I can do it academically, which is great. So I thank you so much for your time and your knowledge. This has been amazing, and anyone that's listening is going to get so much out of it. So I appreciate you.
Hey, it's been great to be here and to meet you, and I love what you're doing.
Thank you so much. Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.